Let's just mute that. Okay, I think we're good to go. So thank you everybody for joining us. We are doing our second journal club this evening, and I'm excited to dive into this paper. I'm going to share my screen here, make sure. And let's see how this is looking. Okay, perfect. So, and for those who don't know me, I am Laura Buchanan. I am a family medicine doctor, as well as board certified in obesity medicine and a metabolic health practitioner. And I'm excited to talk about this very interesting paper that was published not that long ago. 2 weeks ago on Journal Club, you may remember we discussed how potatoes, according to some news articles, could save your life. We actually analyzed the paper and said, oh, that's probably not so true, and talked about a lot of the flaws with nutritional epidemiology and why the paper really just was not of great quality. This week, we're going to be talking more about more catchy headlines that should not be trusted. You may have seen this: keto diet is not heart healthy and may harm the heart, from the Harvard School of Public Health. Other papers: keto-like diet may be associated with a higher risk for heart disease. Keto-like diet may be linked to higher risk of heart disease and cardiac events. New studies suggest it might be harmful. The list goes on, unfortunately. And that brings us to this paper that was just published in June of this year in a prestigious journal, JACC, and it's titled "The Association of a Low Carbohydrate, High Fat Diet with Plasma Lipid Levels and Cardiovascular Risk." And so this is the kind of paper that we're going to be, that the news articles that we were just looking at, where they got those headlines from. The author's conclusion are that a consumption of a low-carb, high-fat diet was associated with increased LDL cholesterol and apolipoprotein B levels, and an increased risk of incident MACE, or major adverse cardiovascular events. We talked a little bit as well a couple weeks ago that there's two big questions you want to answer when you're looking at a study. Does the study show true cause and effect? Is it really valid? And can it be generalized to other people? Meaning, is it externally valid? And you can help answer these questions by going through PICO, or population intervention comparison and outcomes. So it's a method of working through a paper. When looking at the population, they were using a UK biobank that had over 500,000 people initially, with individuals from ages of 40 to 70. To be included in the study, you had to report that you were consuming less than 100 grams of carbohydrates, or less than 25% of your total daily energy from carbohydrates per day. And you just had to complete one 24-hour food recall at any time to be included. And they did this between 2009 and 2010, and they sent out 4 separate 24-hour food recalls during the study period, and then between 2011 and 2012. And then 10 years later, they looked back and said, what did we find? Exclusion criteria. Oh, before we get there, this is the questionnaire of basically with a 24-hour food recall, what did you eat yesterday? And so it might look just like exactly something like this. I had one sliced bread, and then you would put what kind of bread. And there was over 200 common foods that were asked about, and over 32 beverages that were asked about in the questionnaire. We looked at this also 2 weeks ago. Is a single dietary recall appropriate? Because that is what the author's minimum inclusion criteria was: one 24-hour food questionnaire. In this study, where they looked at food frequency questionnaires asking about food intake over a longer period of time, in a less than a 10-year window, comparing the 2 different questionnaires in the same people, there was over a 40% difference in reported number of calories eaten, protein intake, fat intake. And this, again, was just less than 10 years difference. In this study, they were looking at what the outcomes were for these individuals over almost 12 years from a single questionnaire, and then maybe more than one in some, which we'll get to. Exclusion criteria: if you're on lipid lowering therapy, or if you had reported implausible energy intakes, which we'll look at a little bit more closely, then you would be excluded from the study. And then it's really helpful to actually look at the flow diagrams that are in papers. So this is their flow diagram, and I want to highlight a couple different things here. This biobank had over 500,000 people initially. About 200,000 completed at least one dietary questionnaire. Of those 200,000 people, only 2,000 reported consuming less than 25% or less than 100 grams of carb per day. And then if you looked at people who did the baseline survey, you get dropped down all the way to only 300 people out of 200,000 that reported they were eating low carb. And this is a very small number for a nutritional epidemiology style paper. I also want to highlight that 2,000 subjects were excluded for reporting wild energy intakes, less than 800 calories per day or more than 4,200 calories per day for men, less than 500 or more than 3,500 for women. So there was almost 7-fold more people that reported wild energy intakes than actually reported eating low carb. So this just makes me wonder, what are this 24-hour questionnaire actually measuring? Doesn't seem like it's measuring macronutrient intake or caloric intake very well, given that, again, 2,000 people have an implausible energy take and only 300 people put low carb as their intake. Something else you always want to make sure you're looking at is look at the baseline population between the two groups and compare them. So when we look at the low carb group compared to the standard diet group, we see that they are much more likely to have diabetes, have a higher BMI, and obesity. So from the get-go, at baseline, individuals that are eating low carb in this study were more sick. They had more medical conditions. And so that brings up a ton of questions off the bat. Were they eating low carb because they choose that as a therapeutic diet because they were sick and they're trying to improve their conditions? We don't know. So thus far, there's already a lot of issues, right? Nutritional epidemiology, we find there's inappropriate intakes being recorded, so we don't know exactly what people really are eating. A single 24-hour recall is acceptable to then follow these people for 10 years and make claims based on outcomes. They were lower carb technically. There was a very small subject number, only 300 people. Other studies that use nutritional epidemiology often have more than 10,000 people they're looking at. From the get-go, the baseline characteristics show that those who are eating low carb, high fat are less healthy. And we only had baseline lab tests. So what happened over the next 10 years in the group that was less healthy at baseline and in the standard diet group, we don't know. With that, I want to jump into the outcomes. So looking at the total daily energy intake, the other interesting thing is that the group that was eating reported low carb was consuming 500 less calories per day. So the BMI of the low carb, high fat group was higher than the standard group, yet they said they were eating 500 less calories per day. So just like last week, we have beaten SECO, calories in, calories out. We can beat it. You can eat 500 less calories and still have a higher BMI. Again, what were the researchers measuring? I don't know, but it doesn't seem like calories, fat, carbs, protein, exactly. Throwback to last week. Last week, the group that was eating more potatoes, they were consuming more than 700 calories more per day than those eating less potatoes, and consuming more than 700 calories per day, they were less likely to have a BMI over 30. So these individuals were consuming many more calories with a lower BMI. Twice in a row, we have now beaten SECO. here are the reported energy intakes, and it does look like that is true. They're eating lower carb according to their questionnaires, about less than 80 grams per day, a similar protein, and definitely more fat intake in the low carb group. When we start looking at some of the lab values, their ketone levels were a little bit higher, so it makes sense if they're eating lower carb, ketone will be slightly elevated, not in nutritional ketosis, but a little bit higher, 0.06 versus 0.14. When we look at LDL, and this will become very relevant later, the difference between the two is 7 milligrams per deciliter. So 140 in the standard diet group versus 147 in the low carb group. The cardiovascular disease events they were looking at were unstable angina, chest pain, heart attacks, strokes, peripheral arterial disease, and then having stents placed in your heart or in your carotid arteries. Here we can see that the number of events was 50 in the standard diet group and 30 in the low carb group, but that percentage wise is almost 10% in the low carb versus only a little bit more than 4% in the standard diet. So does appear to be higher in the low carb group. They did control for diabetes, smoking, hypertension, and BMI, and that's it, nothing else. So they just controlled for 5 things and said, we're done. There's going to be significant amounts of residual confounding. We already know from the get-go that the low carb group was sicker based on just the baseline data that they gave us. And this is where it gets really interesting to me. So it's always, if you have time and you're trying to analyze a paper, look at the supplements that's given. In the supplement, they reported that there was, and this is, and they were looking at who completed more than one questionnaire. So in that 2-year window, only 54 individuals actually completed a second questionnaire that reported they were eating low carb. And interestingly, in those 54 that did report they were still eating low carb, their BMI was, again, higher than the standard diet group. And this is just, again, you have 54 people out of 200,000 that completed the dietary survey were low carb. When we look at the outcomes of these 54 individuals, the number is there's only 3 that actually had a cardiac event, and it is no longer statistically significant. You can tell because the confidence interval there that's highlighted in yellow crosses 1. And they also highlighted the risk for cardiovascular events based on LDL. And they highlighted this in the paper that if you ate low carb and you had high LDL, you had even higher risk for an event. What was interesting and not really highlighted is that if you ate a standard diet and you had high LDL, that there was not any increased risk of heart disease. In fact, you had a little bit higher risk if you had low LDL in the standard group compared to the standard diet group that had high LDL. Moving on to just go over a couple of quotes from their discussion. They report, as anticipated, diabetes and obesity were more common in individuals reporting a low-carb, high-fat diet, in accordance with common perceptions that this dietary pattern is beneficial in managing these conditions. However, the reasons why certain individuals chose to pursue a low-carb, high-fat diet are unknown, which could introduce both measured and unmeasured confounding. That's completely reasonable. I agree with them. These people potentially went low carb to reverse their medical conditions and were maybe living an unhealthy lifestyle prior. Now, they also said individuals reporting a low carb, high fat diet had a lower total daily energy intake at baseline compared to the standard group. This is in agreement with previous observations that low carb diets may trigger satiety hormones and suppress appetite, leading to a reduction in caloric intake. But does this explain a 500 calorie difference between the control and the low carb, high fat groups with a higher BMI in the low carb group? I don't think so. Maybe it's just bad data, actually. They also said the findings were robust to different variations in degree of carbohydrate restriction, and the changes in lipid levels persisted among participants with greater than 2 dietary surveys with directionally similar associations with MACE. For me, robust is almost comical to use when you have 3 individuals out of an initial population of over really 500,000, but 200,000 that completed a dietary survey. And 3 of those individuals had a cardiac event. And then to try to make that association from the 24-hour food recall from 2 surveys is wildly below robust. And then lastly, in a population-based cohort, self-reported consumption of a low-carb, high-fat diet was associated with increased levels of LDL-C and ApoB and increased risk of incident atherosclerotic cardiovascular events. That difference in the LDL they're talking about, 7 milligrams per deciliter. Not really that big of a difference. And the standard diet group we already mentioned had significantly high LDL group was not in those individuals, that was not associated with a higher risk for heart disease. The authors conclude, to our knowledge, this is one of the first studies to demonstrate a relationship between low-carb, high-fat dietary patterns, increased lipids, and elevated ASCVD risk. And they have in their graphic this heart-wrenching picture showing that low-carb, high-fat diets has a 2-fold increased risk of events with showing plaque clogging the arteries. To me, this is actually very reassuring. If this is one of the first studies to demonstrate this relationship that shows harm with low carb, high fat, given all the flaws that we just went through, I think it's safe to reject these outcomes and continue to eat low carb. And with that, I just want to preview for the coming up in a couple of weeks here, we're going to transition a little bit away from some of this nutritional epidemiology and talk about some really cool papers, this being one of them, about how the ketogenic diet can really help individuals with different mental health conditions. And with that, we will leave it open to for some questions. And
I have one.
Awesome.
So why do you think these papers are not only frequently published, but also published in like the Journal of American College of Cardiology, which is, a prestigious journal?
Yeah, so that is a great question. Sorry, I just got a tickle in my throat. Give me 1 second. So I wish this was something we didn't keep on seeing, but alas, we do. And there's 2 problems here. There's incentives for both journals and researchers to continue to publish this type of data. This paper was published in the Journal of American College of Cardiology, which is a very prestigious, high-ranking journal. And if you were to look at their other research studies, they have much more rigor, and they, I would say, are robust in their data collection and their analysis. And especially with their randomized control trial. So very good quality data is published in this journal. However, the one thing that we see is these anti-ketogenic diets that keep getting published promote clicks and views, which is great for the journal. We saw the news headlines that get created, and that is really good for the journals. So it increases the brand of the journal. And I think that's one of the things we see there's these incentives to the journals to publish poor data. And then the other aspect is the authors, because they have to be very smart people. And so I think it's just an unfortunate kind of paradigm we've gotten where if you are a researcher or a physician who's also working to get things published, or you're working in an academic center, you have to publish more papers to actually get promoted in the academic setting. So the more papers you publish, the higher the chance that you will actually get promoted. And so if you are the first or the last author, then that's even better. The problem is there are databases all over, just like the UK Biobank, where you can go look into these databases and then just pick any number of things you want to research, and you can make and find associations. So I'm sure we could go look at the UK Biobank and look at some more food frequency questionnaires, and I could find somehow that a specific type of fruit is probably going to increase your risk for heart disease. You could probably even manipulate the data in such a way that a certain quantity of red meat, just like 14 or more potatoes was lowered heart disease risk, maybe 5 steaks would lower heart disease risk. That's,
Yeah.
you just can mine the data and then you can get a publication and boost your career. So I think there's misaligned incentives, and then also not, there is pressure put on the researchers to get things published and get funding.
Yeah, and another popular question is, does the amount of cholesterol in your food have an effect on the amount of cholesterol in your blood?
Yeah, so that used to be thought it had a large impact, but really over the many years now, it's kind of been debunked that eating cholesterol does not significantly impact your blood level cholesterols. If you were to go extremely low fat, extremely low cholesterol, you might be able to have an impact, but we're talking tiny amounts.
Yeah, Shelley had put the version of low carb being less than 100 grams per day is far from low carb. Yeah.
Right, yeah, the very low carb diets that we're used to are really less than 50 grams. And so there's some definitions that will use less than 130 grams is low carb, although it is not very low carb, definitely nothing that's going to get you into ketosis.
Yeah, and then Greg asked, are researchers using any sort of AI to make these conclusions possibly?
That is a great question, and I think it's in our day and age very plausible, very possible.
Mhm. Another one is, let's say you're new to following a ketogenic or a low carb diet for heart health. How long does it actually take before improvements can be expected in the blood tests?
Yeah, great question. So it depends on the individual. Say I'm working with someone who has diabetes and their A1C is 10. When we repeat their A1C in 3 months, that's going to be drastically lower. You're also going to, I mean, if they have elevated triglycerides, which we see really commonly, that's going to be cut in half, maybe more. Sometimes it takes a little longer, but usually that is a very quick find. So typically by the first repeat in lab test, you'll already start seeing improvements.
Okay. One other question we have is, since high cholesterol doesn't always cause heart disease and lower cholesterol doesn't always prevent it, does it make it sense to aim for having a low cholesterol level as possible?
That's kind of one of these theories now is if we could just get everyone in their 20s or younger to have a really low cholesterol from the get-go, basically, primordial prevention. We get everyone on multiple medications, then we prevent heart disease. I think that you're asking for potentially a lot of side effects and other long-term risks that we don't know from lowering cholesterol. We've seen associations with increased cancer and increased infectious risk. So I think that would be a huge gamble that I would not be willing to take. And the other thing is if you really tried to get everybody's cholesterol that low, again, you would be putting an entire population on multiple medications.
Yeah. Let me see.
Great
Oh,
question so far. Yeah.
yeah. Another one is, should you be worried about elevated LP little a?
Yeah, so that is something we check on everybody. I think I always, if yours does come back elevated, I wouldn't say immediately be worried, but that might be an additional reason to just do everything else you can to help decrease your risk for heart disease. And so one step back, LP little a is more of a genetically driven cholesterol particle that does put you at a little bit higher risk for heart disease. Compared to other lifestyle things like hypertension, diabetes, the risk is still not this as great as those are, but it is an independent risk factor. And so if you do have one genetically that's high, then you want to be doing everything you can to combat that. So I've seen people in their 60s and 70s who have very high LP little a's, and we check a calcium scan and their score is 0. They have no evidence of any plaque buildup. So just because it's elevated does not mean that you are destined to have a heart attack or to have plaque evidence if you get a calcium scan. So I think it's just another motivating factor to try to work on optimal lifestyle.
Thanks. Anybody else have any questions out there? You can ask us anything.
Awesome. And I have not been on, if for those who are watching live, sorry, I've not looked at Twitter to see if anybody has posted anything asking questions there. You can look at that real quick, just see. No, it doesn't look like it, I don't think. Awesome. Well, no harm in ending early. It was
Yeah.
great questions. If you do have a journal article that you would like to be reviewed, definitely please send it our way, and maybe we'll take a look at that.
Oh, one more question came in. Why isn't there a standard definition of low carb for these studies, like under 50 grams?
That is a great question, and I think it definitely needs to be standardized. The problem is there's not been large medical organizations that have come out to really give definitions. But I think, at the SMHP, the Society of Metabolic Health Practitioners, we do have cutoffs in our guidelines. And the hope is that we can make other research studies, and as people become more familiar with low carb and ketogenic diets, is maybe they will start using proper terminology in the paper.
Good questions, guys.
All right, awesome. Well, I look forward to seeing everybody here in a couple weeks, and I hope everyone enjoys their Tuesday.
Bye, everybody.
Bye.
Oh, one more question just came in.
Let's see.
That's all right.
Yeah, that's
And
all
then
right.
she said bye. Sydney said bye.
Yeah, I agree.
Yeah. That was fun. Well, thanks. I think that went really, really well. Sorry, I should have compiled a few more
No,
questions, but those went well.
that was perfect.
Do we have to hit end recording or did you do that?
No, it's still live stream.
Okay.
So we're all good. But I'm gonna head out. Bye.